Welcome, ladies and gentlemen, to today's tutorial. Today we are going to look at the radial nerve. We already seen two of the long nerves, yes, that we find in the upper limb, being the radial, being the ulnar nerve, and of course the median nerve. These two nerves supply, the anterior compartment of the forearm, give motor supply to the muscles of the anterior compartment of the forearm, as well as of course the hand. In addition, they also give cutaneous sensation to the palm as well as the dorsal part of some portions of the hand. Now, visit that video of mine which I've explained, the median nerve as well as the ulnar nerve. Please also visit what we call the brachial plexus to get, understanding of what we are going to look at, the formation. I've done a video on that too. Today, we are interested in the radial nerve. Now, for the radial nerve, it's actually going to start, continuation of, the posterior cord of the brachial plexus. It's a continuation of the posterior cord of the brachial plexus. Therefore, it will run posteriorly to the third part of the axillary artery. Apart from this, what happens is that its root value, is coming from actually C5 to T1 ventral rami of the brachial plexus. Now, what happens is that it runs in the axilla. It gives us some branches. It goes into what we call the spiral groove. It goes anterior to the lateral epicondyle. It pierces through the two lamina of the spinator muscle, to enter and give off those branches. Now we are going to look at all these things. So without much ado, let's look at the radial nerve. But one thing that we have to know about the radial nerve is that it's going to give motor supply to muscles of the posterior compartment of the arm, so that they can cause extension of the upper limb at the elbow joint. Again, there will also be extensors of the forearm going to give supply to them. Apart from that, some cutaneous branches. We are going to look at all these ones. And then again, it's going to supply the lateral third of what we call the brachialis muscle. I've done all these videos, so visit my YouTube channel, get all these videos to watch for better understanding. So, as we said, the radial nerve is going to begin in the axilla, going to as continuation of the posterior cord of the brachial plexus. So, in the axilla, this radial nerve, which you find here, moving this way, we are going to look at it, is going to, give rise, in the axilla, it's going to give rise to some two main branches. One of them is actually coming to innervate the medial cord, the medial, head, as well as the lateral head of the triceps brachii muscle. That's the lateral head, the long head of the triceps brachii muscle. So the medial head, as well as the long hairs of the triceps brachii muscle, are getting their innervation right from the axilla. So that is what is going to happen in the axilla. Please get to know where these, innervations of these, muscles are coming from, so that it will help us in the clinical application. Now again, in the axilla, it also gives a cutaneous branch, and this is the cutaneous branch that we find here, to actually the posterior part of the arm. So over here, the posterior part of your arm, the cutaneous sensation that you are going to feel over here will be actually coming from the axillary region. Now it leaves the axilla, the nerve leaves the axilla to actually enter, the upper limb, the arm region, by going through what we call a triangular interval. So it actually enters what we call the arm by going through what we call the spiral groove. There's a groove known as spiral groove. Now in the spiral groove, not only do we have the radial nerve, but we also have what we call the profunda brachii artery, this one, which runs with it. Actually, it's a bit medial to, anterior to what we call the, radial nerve. Now, in the axilla, this nerve will give off some branches. It's going to give motor branches, actually to what we call the lateral head of the triceps brachii muscle, okay, the lateral head of the triceps brachii muscle, will be getting its innervation in the, spiral groove. Apart from this, also the medial head of the triceps brachii muscle will also getting its innervation again. So remember that the medial head of the triceps brachii muscle, which you can see here, will be getting actually dual nerve supply from the radial nerve, one in the axilla and one in the spiral groove. Now, in the spiral groove again, remember the reason why we are going to call this spiral groove also radial groove is that the radial nerve, goes through it. I said that accompanying it is the deep artery of the arm, profunda brachii artery. Okay. Now, remember that in the radial groove, other nerves are also going to come up, and there are going to be two cutaneous nerves which are going to arise from here. And these two cutaneous nerves are one, lateral cutaneous nerve of the arm. Actually, the one who is going to be a bit inferior. Now, at the point where what we call the deltoid muscle inserts, the deltoid muscle is here. It inserts on the deltoid, tuberosity on the lateral aspect of the shaft of the humerus. Beyond that, that cutaneous sensation will be coming from actually the inferior, aspect of the, lateral, cutaneous nerve of the arm, which is actually coming from, the spiral groove, coming actually from a branch of the radial nerve. Remember that the superior one will be coming actually from the, axillary nerve, which we'll look at later. Now, in there again, we also have a branch, okay? We also have another branch in the spiral groove. There will be another branch. Okay, this branch that you find here is, the posterior cutaneous nerve of the forearm. Posterior cutaneous nerve of the forearm, the one you find here, where it's actually going to give, cutaneous sensation, actually to the lateral half of, the forearm. Okay, lateral half of the forearm. I'm going to give cutaneous sensation here. So that's what we are going to find. So that's the posterior cutaneous nerve of the forearm. Now, beyond that, okay, the nerve pierces through what we call the lateral intermuscular septum. Okay, pierces through the lateral intermuscular septum and gets all the way into what we call, runs anterior to what we call the lateral epicondyle. Okay, so the lateral epicondyle is here, and it will run anterior to what we call the lateral epicondyle. But before it gets to the lateral epicondyle, it gives off two main important nerve supply, which you have to know for clinical application. It's going to give rise to a much higher level. Okay, it's going to give rise to what we call branch to what we call the brachioradialis muscle. Okay, this is the cast section of brachioradialis muscle. Okay, the ones you see here. So give branch before it runs anterior to what we call the lateral epicondyle. Is going to give branch to what we call the brachioradialis muscle. In addition, at a lower level, it also give branch to what we call extensor carpi radialis longus. Extensor carpi radialis longus. Yeah, so you can see the tendon. Usually these nerves, they become a bit clumsy, in the proximal aspect. So we want to trace, the tendon inferiorly. Extensor carpi radialis longus. So it's also going to give, motor supply to this nerve, before it enters anteriorly to the lateral epicondyle of the humerus. So that's one important thing that we have to, appreciate. Now, it actually pierces after, so it becomes a content, from there, it becomes a content of what we call the cubital fossa. I've done cubital fossa anatomy, so please can go and look at that one. So as you said, it will be the lateral most structure, which you'll find it in the cubital fossa. Just in there, okay, it divides into two. It gives a superficial branch, which you can find here. This superficial branch actually runs all the way. As you can see, it's running actually on top of this muscle, which we call it the supinator muscle. Run on top of this muscle, supinator muscle. yes, actually crossing superficially on what we call the pronator teres muscle, okay, to actually, pierce, okay, run inferiorly to, the brachioradialis, to pierce through it, to actually run superficially to supply actually the lateral the dorsum, lateral 3.5 of the dorsum of the hand, okay. So the superficial branch, which is a terminal branch of, the continuation beyond what we call the, lateral epicondyle anteriorly. The superficial branch is going to go all the way to supply, okay, give cutaneous sensation to what we call the lateral 3.5, okay, lateral 3.5 all the way here, as well as the dorsum of, the hand here, lateral 3.5 of the dorsum, excluding the nail base, so get to know that, excluding the nail base. So over here are not parts of it. All right, now the deep branch, okay, the deep branch actually pierces, okay, so this is the deep branch, the one you find here. This is the superficial branch which we've seen, going to give cutaneous sensation. This one over here, the little one here, which is piercing through the two lamina or the two hairs of the supinator muscle, is the deep branch of the radial nerve. Remember that the ulnar nerve pierces through actually, the flexor carpi ulnaris muscle. Please visit that video to get more insight. Remember that the median nerve, okay, pierces through the two hairs of what we call the pronator teres muscle. For the radial nerve, it will pierce, the deep branch will pierce, okay, enter the forearm, actually by piercing through the two lamina or the two hairs of what we call the supinator muscle. So remember that in there it is going to supply the supinator muscle. Remember that the supinator is going to be relevant for supination. So remember all these areas. So there could be injuries to these areas, and you know which muscles will be affected or which cutaneous branch will be affected. So it runs all the way deep to it, okay, and then give supply, actually running, posterior to actually the interosseous membrane. So that becomes beyond, okay, after piercing through the spinator muscle, we now call it, beyond that area, we now call it posterior interosseous nerve. So this one is the deep branch. This one is the deep branch of, the radial nerve. But after piercing through the two hairs of the spinator muscle, it is now called the posterior interosseous nerve. So the posterior interosseous nerve will supply, muscles of the posterior compound of the forearm, which are actually, extensors. Okay, extensors. So please visit the video that I've done on the, myology of the posterior compound of the forearm to get more insight. Now you get to see that, yes, this muscle, which is over here, giving off all these tendons. So there's the extensor digitorum is going to get a supply. Yes, even the, the anconius is going to get a supply in the, the anconius will be getting a supply area. So all these muscles, this muscle, okay, getting the little finger, okay, that's the extensor, indicis, okay, extensor indicis, all right. Sorry, the extensor digiti minimi, yes. Then we also have the extensor indicis as well, which is actually deep, okay. So all these, muscles will be getting their supply from the posterior interosseous nerve, which is a branch, the deep branch, continuation of the deep branch of the radial nerve. So for you to get more understanding, please visit the myology that I've done to get more insights. It's going to supply all these muscles. Now, importantly, one thing that we have to look at, but let me just show you these ones. Yes, this muscle over here, which is going to the thumb, okay, contributing to this nerve box. There's the extensor pollicis, longus, okay, extensor pollicis, longus, this muscle. Sorry, extensor carpi, radialis, longus. Okay, extensor carpi radialis longus over here. So now all these, yes, there's the extensor retinaculum. Please get to understand all these things by visiting that video. So all these muscles are going to get their supply from, the deep branch, actually the posterior interosseous nerve. Now, this nerve can be compressed at several areas. Now, one important area that it can be compressed is in the axilla. Okay, now in the axilla there could be dislocation of the shoulder joint, yes, especially at the inferior aspects. It could actually be posterior, anterior dislocation, or even inferior, but more especially going to be the inferior one, yes, because that's where it is a bit deficient. The capsule is less compared to the anterior and posterior aspect, so it can be dislocated inferiorly. Remember again that sometimes there are some individuals who don't use their crutch very well. The crutches that they use, it's not well, it's either too long for them, therefore it will result in injury. And this injury at the median nerve using this crutch is known as crutch paralysis. Now if there is crutch paralysis, then it means that you can actually extend your upper limb at the elbow joint. Why? Because extend it to, this is actually the flex position. You can extend it at the elbow joint, because what happens that we saw that some of the hairs of the triceps brachii muscle were getting their innervation from. So all those areas, yes, you can flex. You can extend at the elbow joint. Again, you can also, yes, you can extend all these muscles. You can also supinate, so the hand will be pronated. There will also be what we call wrist drop, because all the for instance, extensor carpi radialis, longus, and brevis, as well as extensor carpi or naris, will all not get their innervation. So it's going to result in a situation that it will result in such a situation. Okay, so that this one you can extend it. Okay, and then again there's wrist drop, because all the extents of the wrist are not there. There's also going to be what we call finger drop, because what happens is that extensor digitorum is also not getting its nerve supply, so there will also be finger drop as well. So if you see someone with this, then it's likely that the nerve injury is actually coming from what we call the axillary region. Now again, there could also be another injury to actually where we have the spiral groove. Okay, there could be injury this way. So if there's mid-shaft fracture of the humerus, it can affect it. Okay, and that one could result in other things that we are going to see. Again, there could also result in when you rest your arm, posterior aspect, actually on, let's say, a hard object, let's say a chair, okay, for a very long time, it could result in actually what we call Saturday night palsy. Saturday night palsy. So let's say after drinking very long hours on Saturday night, and of course when you just go and then of course rest just anyhow, resting your arm on a chair, then it can actually result in what we call Saturday night palsy. So there could be injury to the radial nerve in the axilla, in the radial groove. Now, if it's affected in the radial groove, we know that the long head as well as the medial head of the triceps brachii are getting their innervation actually a bit upper, in the axilla. So it means that there will be, weakness in, extension, but there wouldn't be loss of extension. It's just going to be weakness. Again, in addition, because cutaneous sensation is all the way coming from actually the the axilla, the posterior part, there will not be loss of cutaneous sensation. But what is going to be lost will be that, yes, there will be what we call, there will be wrist drop. Okay, so this one can be extended, but there will be wrist drop. Okay, there will also be finger drop, because extensor carpi radialis, longus, and brevis, as well as extensor carpi ulnaris wouldn't get their innervation. Again, extensor indicis, as well as that of the digiti minimi, and of course that of the indicis will not get, and therefore there will be what we call finger drop as well. Okay, so these are the things that we look at. Again, there will be there will be loss of cutaneous sensation as far as the forearm is concerned. Apart from that, the aspect over here, okay, in the forearm is concerned, cutaneous sensation will be lost over here. Again, there will be cutaneous sensation loss in the lower part, okay, laterally of the arm, below where the insertion of the deltoid muscle. Now, so that's what we have to present. That's what is going to see happen. Now, the next one will be injury if there is fracture to the head of the radius. Okay, if there's fracture to the head of radius, remember that if there's fracture over here, then all those things below it will be affected, but those above wouldn't be affected. So there, for instance, there wouldn't be any problem with extension at the elbow, okay, upper limb at the elbow. There wouldn't be any problem with cutaneous sensation, yes, which we've seen for that of the forearm, posterior aspect of the forearm, that of the arm, as well as the lateral aspect, lower lateral aspect of the arm wouldn't be affected. Yes, in addition, there wouldn't be any wrist drop. There wouldn't be any there wouldn't be any wrist drop, because one of the extensors of the wrists is spared. That is extensor carpi radialis longus will be spared. Therefore, because getting its innervation right before it enters the anterior aspect, anteriorly to what we call the lateral epicondyle. So that one will be spared. So in such situation, there wouldn't be any wrist drop, but there will be finger drop, because the extensor digitorum wouldn't get its supply. That of the indices, and that of the digiti minimi will not also not get their innervation. So these are the things that we have to look at. Now, if however it is fractured around this area where we have the posterior interosseous nerve, then it means that all those extensors below that area will be affected. Okay, so that of the extensor indicis, extensor digitorum. So there will be wrist drop, okay, at actually the metacarpal phalangeal joint. There will be wrist drop, but there wouldn't be there will be finger drop, but there wouldn't be wrist drop. Okay, there will also not be problem with extension at the elbow joints. There wouldn't be any problem with cutaneous innervation. Why? Both cutaneous innervation actually of the dorsal lateral half of the hand, because it happened to the posterior interosseous nerve. For the superficial branch, it's going to supply the dorsal aspect, so that one would not be affected. So depending on where the injury occurred, whether it occurred in around the head of the humerus, or in the area forearm around where we have the posterior interosseous nerve, these differential diagnosis will help. Is there any cutaneous sensation over here? If there is, then the fracture is at where the posterior interosseous nerve is in the forearm. But if cutaneous sensation to the dorsal terrain half of the ligates, as well as the dorsum of the hand, okay, then it means that what will happen is that it's actually coming from area where we have the head of the radius. That's where the fracture is coming from. So these are the things that we have to actually look at when we want to talk about all these problems regarding these ones. Now, one thing that we have to get to know is that we've looked at the long nerves of the upper limb, being the median nerve, being the ulnar nerve, being the radial nerve. One thing that we have to understand is that all these nerves could be tested with a thumb. All these nerves could be tested with a thumb. And how do we do that? We know that adductor pollicis, okay, it's actually by the help of the ulnar nerve. So by just doing this, you're able to test whether the ulnar nerve is intact. We also know that we have some muscles that we call them thenar muscles, apart from the adductor muscle, being supplied by actually the median nerve. Therefore, we can test the median nerve by actually testing for position movement of the thumb, because we know that abductor pollicis brevis, okay, there will be another muscle which is known as abductor pollicis longus. So if the brevis is out, then the longus, which is coming from the forearm, can serve the function of abduction. And we also know that we have flexor pollicis, brevis in the thinner area. Therefore, it means that there's also flexor pollicis longus. So if the brevis is not getting its innervation and it wastes, cannot perform its function, then its function could be augmented, okay, by what we call the flexor pollicis longus. It's only opponens pollicis, which you don't have opponens pollicis brevis or longus. Therefore, there's only one muscle for operation movement of the thumb, which is also getting a supply from what we call the median nerve. Therefore, the median nerve could be tested by just operation movement of the thumb. Again, for the radial nerve, we can test it with the thumb by way of, yes, actually flexion of the thumb, because the flexus, flexor, pollicis, longus, okay, flexor pollicis brevis, they are all getting their supply from what we call the radial nerve. Therefore, by way of, flexing it, you are able to test for what we call the radial nerve. So, ladies and gentlemen, I hope it was helpful. Please ensure that you visit all those videos that I've recommended to get better understanding, as far as especially the muscles, their insertions are concerned, to get to know which muscles are there. Thank you very much for your audience. May God richly bless you all.